Good morning, everyone. Good morning. The appointed hour has arrived, so we'll go ahead and kick off our event this morning. My name is Jim Capretta. I'm a visiting fellow here at the American Enterprise Institute, and I'm very pleased to welcome you to this event on the release of a report that we put together called Improving Health and Healthcare: An Agenda for Reform. We'll be talking much more about that as the morning proceeds. Let me begin by first thanking the Peterson Foundation for providing some support for this project that allowed us to proceed with the work associated with it. Without that support, we really wouldn't have been able to do it, so we're very, very grateful for that. Shortly, I will provide a brief thematic overview of the contents of the report. And by the way, when I say we, in that sense, that's not the proverbial royal we. The report has 10 co-authors, myself and 9 colleagues, and I have great respect for all of them, and I'm very pleased that I was able to work with all of them on this. After my presentation, we will then have a panel with additional perspectives, including from 4 of the plan's co-authors, as well as 2 expert discussants. That panel discussion will be moderated by my AEI colleague, Joe Antos. But before we get to any of that, we are very pleased to welcome Representative Tom Price to AEI to kick off our event this morning. Congressman Price represents the 6th Congressional District of Georgia and has been serving in Congress since January 2005. He is an orthopedic surgeon and was in private practice for nearly 20 years before getting elected to Congress. Congressman Price has become a real leader on both healthcare and fiscal policy issues while in Congress. He is now serving as chairman of the House Budget Committee. He sits on the Ways and Means Committee. And in the past year, he successfully negotiated with his Senate counterpart at the Senate Budget Committee a budget plan to balance the budget, and it was adopted by Congress. That's the first time Congress has adopted a budget plan in several years, much less a balanced budget plan. So he deserves a lot of credit for shepherding that through a complicated process. For our purposes today, it's also very, very noteworthy that he is the author of Empowering Patients First Act, H.R. 2300, one of the most prominent and well thought out plans to replace the Affordable Care Act that's been introduced in Congress. He's been working on it for several years and keeps refining it, and it's quite an excellent proposal. Much of it we borrowed liberally from. He's the perfect person to get us thinking about these important topics today. So without further ado, please welcome Representative Tom Price.
There you go. He's not Jim Capretta. Thank you, Jim, so much, and thanks for that wonderful, kind, and generous introduction. I can't tell you how excited I am to be back here at AEI and discussing an issue that is near and dear to my heart, and truly the issue that drove me into public service. So thank you for the opportunity to be with you. It's an incredible honor to be with so many great thinkers in the area of healthcare, and I'm really humbled by the collection of folks that have participated in this project. The passion and the for service and for helping others that drove me to go to medical school and complete medical school and practice medicine for over 20 years is the same passion that encourages me in this current debate that we're having about healthcare. And I want to once again congratulate those who participated in the work product that's going to be presented to you today. This is an incredible contribution to the discussion that absolutely must occur as it relates to healthcare. 5 or 6 years ago, President Obama, along with congressional Democrats, put in place a sweeping set of reforms in the area of healthcare to remake the American healthcare system. And unfortunately, what we've seen over the past several years is that in many ways the law has done more to break the healthcare system than to improve the healthcare system. A majority of Americans right now believe that the system that we have, the law that we have, is not what they would desire. Now, if we're scholars and if we're objective and we want to actually get to a correct solution, it's imperative that we step back and say, why? Why is it that the majority of Americans continue to believe, and somewhere in increasing numbers, believe that the health plan that we're on, the health path that we're on, is not the right path? And let me suggest to you that the reason is that we are not following the American people's principles as it relates to health care. Many of you have thought about health care principles. Some of you may not have thought about health care principles. Everyone has health care principles. If you had a clean slate and you were given the challenge, what kind of health plan, health program, health policy would you come up with? What principles would you follow? Most people have the top three. We want a system that's accessible for everybody. We want a system that's affordable for everybody. We want a system that's of the highest quality. I add three to those heroes of healthcare principles. I think you need a system that's responsive. Got to have a system that's responsive to the patients. We need a system that incentivizes innovation. And we need a system that provides choices for patients. Patients need to be the ones that select who's treating them when and where and the like. So accessibility, affordability, quality, responsiveness, innovation, and choices. Let me suggest to you that the reason that the American people in big numbers believe that we're going in the wrong direction is because the current policy of our nation violates every one of those principles. Every one of them, regardless of what your ideological stripe is, our policy violates those principles. So affordability is decreasing. Accessibility is decreasing with the narrowing of the networks. Quality is decreasing. You can make a pretty doggone good argument about that. When I hear from my physician colleagues back home, they tell me that they're not able to provide the kind of service that they know that their patient needs so often, and it's not because they've forgotten how to do it. It's because the rules have pushed them into a situation that won't allow them. Responsiveness, innovation, choices, clearly all of those things are compromised. So we violated those principles, and people continue to believe that something else needs to be done. In short, the plan that we have right now doesn't work. It doesn't work for patients, it doesn't work for docs, it doesn't work for employers, it doesn't work for employees, it doesn't work for states, and it certainly doesn't work for the federal government from a financing standpoint. So we will continue to see the erosion of support and the erosion of participation in this program until we move in a different direction. The most recent example was the announcement of the United Healthcare just last week or the week before, that they look to 2017 and believe that they're not going to be able to, this is one of the largest insurance companies in the country, they're not going to be able to participate in providing coverage through the exchanges. Again, not because they've lost their desire to provide health insurance coverage for folks, but because it doesn't work. The system doesn't work. Therefore, it's incumbent upon all of us who have a passion for this area of public policy to come up with positive solutions, and hence that's why we're here today. Now, conservatives and Republicans have been accused of not having a plan. You've heard that, right? Republicans don't have a plan. Conservatives don't have a plan. You still hear it. It's patently untrue, as you well know. In fact, we probably have too many plans. There are about 150, 160 pieces of legislation that have been introduced in Congress on the Republican side to address health care. And when you have that number of plans and you haven't coalesced around a plan, then you don't have any plan. Again, I think it's incredibly important, the work that's been done today. This is one of the reasons that this event is so vital for us, and I want to once again thank folks who contributed to the work product here. From my perspective, there's no better time than right now. Right now, to be able to move forward with a comprehensive plan for health reform. This is the moment. This is the moment to lay the foundation on the Republican side, on the conservative side, for putting forward positive solutions so that in 2017, when hopefully, we have a president who's truly interested in moving forward with positive solutions as it relates to health care, we'll be able to have laid the groundwork, laid the foundation to be able to hit the ground running at that time. I can't tell you how excited I am about the new speaker, about Speaker Ryan being in place. He has challenged every one of us, regardless of our policy passion, to work and come forward with positive solutions in 2016, not 2017, in 2016 that address the challenges that we face. And so he has put down the gauntlet and said we need to come up with legislative proposals, not just principles, but legislative proposals to address these challenges. And as so many have in the past, as I mentioned, on the Republican side, put forward health care positions or health care solutions, what we need to do is come forward with a plan. Coming forward with a single plan will accomplish two specific goals. One is to build the momentum, as I mentioned, for reform and to lay that foundation for action that is absolutely vital in 2017, as I suspect you all believe. The second is as important, and that is to dispel this myth that conservatives or Republicans don't have any plan to put forward as a positive alternative for Obamacare. It's important to push back on that narrative. I've had a piece of legislation, as Jim mentioned, now for 6 years. We continue to refine it, but until we rally around a single plan as conservatives and as Republicans, I think that we'll continue to be subject to the demagoguery from the other side. Now, if we adhere to those principles, accessibility, affordability, quality, responsiveness, innovation, and choices, if we adhere to those principles, what's a plan look like? What's it look like? Let me suggest that it looks a lot like the plan that you're going to be shown today from the scholars that have worked over the past number of months on it. I call it patient-centered healthcare. What that means is patients and families and doctors making medical decisions and nobody else. I think that's the important principle. If we keep patients at the center, then we actually get to the right solution. You can't have government at the center. You can't have insurance companies at the center. You got to have patients at the center. And when we do that, then we get to the right solution. The solution that I put forward, as I mentioned, for the last 6 years, H.R. 2300, the Empowering Patients First Act, is one of those that I think addresses things in a positive way, would get every single American covered with insurance that they want. Not that the government forces them to buy, insurance that they want. We do it through a series of tax credits, refundable credits, advanceable refundable credits, so that every American has the financial feasibility and wherewithal to be able to purchase the coverage that they want. It's important to solve the insurance challenges that are out there. The two biggest ones are portability and pre-existing. Nobody ought to lose their insurance if they change their job or they lose their job. Nobody ought to be priced out of the market if you get an awful diagnosis. Both of those things may work for government and may work for insurance companies, but they don't work for patients. And H.R. 2300 solves those in a way that doesn't put Washington in charge. You don't have to put Washington in charge of these challenges in order to get to a solution. H.R. 2300 also would save hundreds of billions of dollars through a robust lawsuit abuse reform policy. I think it's one of the keys. The biggest waster of dollars in the healthcare system today, I would suggest to you, is the practice of defensive medicine. It's what physicians do. Every physician does, if they're honest with themselves. It's tests and procedures and examinations and the like that are done not necessarily for the patient's benefit. It doesn't necessarily harm the patient in any way, but it's not necessarily for the patient's benefit. They're done so that the physician is able to, if he or she is ever called into a court of law, is able to say, I don't know what you wanted me to do because I did everything. When in fact everything is rarely necessary to either treat or to diagnose the patient. The waste of money in the practice of defensive medicine is estimated somewhere to be between $400 and $600 billion a year. A year. We spend about $2.7, $2.8 trillion in healthcare, pushing $3 trillion annually a year as a nation. $400 to $600 billion is a huge amount of money. Even if that estimate is off by a factor of 50%, $200 to $300 billion a year is still a huge amount of money. So H.R. 2300 is the bill that we've put forward, and I'm happy to answer any questions on that if you have any questions. So what's going to happen? Where are we? What's going to happen as we move forward? I think regardless of who is successful next November in gaining election to President of the United States, regardless of who that person is, and regardless of party, let me suggest, that some significant health reform will be necessary. The President is going to need to embrace health reform because, again, what we've got right now violates all of the principles that the American people hold dear, and it doesn't work. So we're going to have to move in a much better direction. It also, the solution, I believe, needs to be bipartisan. We know what a partisan solution looks like. It's where we are right now. Doesn't work, violates principles. What we need is a bipartisan solution. The current path for Medicare and Medicaid is not sanguine. Medicare is going broke. These programs are going broke if nothing is done. People who tell you that nothing needs to be done to save and strengthen and secure these programs are simply wrong. They're not telling you the truth. So what we did in our budget is put forward proposals to be able to save and strengthen and secure Medicare and Medicaid. And I want to commend again the plan that you're going to see rolled out today for addressing the issue of issues of Medicare and Medicaid. The plan ought to be commended for addressing all of the health systems that we have. And we've got 4 or 5 large health systems, right? We've got Medicare, we've got Medicaid, we've got the private system, you've got the VA system. You can argue that the Indian Health Service is a completely different system as well. As a tangential thought, did you ever think about why we have multiple systems of health care in this country? Why wouldn't we just have a single system? Not a single payer system, but a single system that allows every single individual to access it at different points depending on what plan they're in, whether they're in a private plan, whether you're in a Medicaid plan, whether you're in a Medicare plan, whether you're in the VA. Why should those systems be siloed and different? That's another discussion, actually, and maybe saved for another day. So the entire system needs reform, and this proposal that's been put out, I think, is incredibly important. But it doesn't exist yet. Huge reform, even the critical mass for reform doesn't exist yet. In our budget that Jim referenced this year, we put forward the proposals to solve these challenges. We've got agreement with the Senate, got agreement on a budget that balances, that saves over $5 trillion over 10 years, doesn't raise taxes, doesn't put Washington in charge of things, puts us on a path to solving Medicare and Medicaid. And then what happens in this town, as you well know, is that everybody releases the press release on the budget that they voted for and passed, and then few people want to follow the budget. So the critical mass of individuals that are needed in order to enact these policies doesn't exist yet. So at the Budget Committee, we've instituted a project that we call Restoring the Trust for All Generations, which is a project that doesn't define the solution for these things, but it is an effort to try to gain that critical mass for folks who will stand up and say, we've got to solve these challenges. Not just here in this town, but across the country. I believe that unless and until the American people stand up and say that they demand of their representatives and of their senators that we've got to solve these challenges of Medicare and Medicaid and other mandatory spending programs that, again, are all going broke, until we get that critical mass, we'll not be able to generate the political muster to be able to do so. So the danger to beneficiaries right now, because all these programs are going broke, is not from those of us who want to push reform, not of those of us who have put forward positive solutions. It's from the individuals who have stuck their head in the sand and say nothing needs to be done. That's where the danger lies. And we're just a few short years away from a point where we're not going to be able to, as a society, to fulfill the promises that we've made to beneficiaries. That's not a comfortable place to be with. So we've got to be ready to act. A few cautionary notes before I close, and then look forward to some questions, I hope. First cautionary note is a big one, and that is how are we going to define quality? Who are we going to allow to be the entity or the individuals that define quality? And let me suggest that if we allow the federal government to define what quality health care is in this country, everybody loses. Everybody loses. Because if the government thinks that quality is something different than you think is quality as a patient, guess who wins? So it's imperative then all of these reform proposals that are put forward that we prescribe for quality definitions to be put in the right spot. And from my standpoint, that needs to be with patients and with physicians. It needs to be with specialist societies, scientists who understand and appreciate what in fact quality is. What I've never been able to get a federal bureaucrat in the area of healthcare to be able to admit is that one individual with a certain diagnosis, the quality care for that individual, may be completely different than the quality care for another individual with exactly the same diagnosis. because those two people are different. They're individuals. They have different situations, different comorbidities, all the kinds of things that make it, that go into how physicians and other providers decide what is best in terms of quality for a patient. So we need to be wary about who's going to be defining quality. Second, cautionary note is a kind of a corollary to that, and that is we in this nation, you think about it, when we look at quality in this country, when we regulate quality in this country, we look at every single incident of care in this country is regulated. Every incident. So when you go to your doctor, if you have your blood pressure taken or not, that incident is regulated, which means somebody's got to check on that. Whether or not your doctor smiled at you, whether or not you thought you waited the right amount of time in the waiting room, whether or not you the plan of action was what you thought it needed to be. Let me suggest to you that when we do that, then we don't provide quality for anybody, because it's an impossible task, costs way too much money, and it is incredibly ineffective in regulating quality. So what if we did what scientists do everywhere else, and that is use the bell curve? What if we looked at just the outliers? The folks who are out here providing more care, too much care, depending on the definition. Either they're caring for sicker individuals, a sicker patient population, or having more health challenges among that population, or they're doing too much. And those folks ought to have to be held to account. At the other end, if for folks who aren't providing the right amount of care, too little care, maybe they're in their retirement years. Maybe they've got a practice that is actually seeing well patients, and that's how they've defined it. Or maybe they're not doing enough when they should be. And those are the individuals that ought to be helped to get up to speed. Whether or not, if you're in the middle of the bell curve, whether or not Mrs. Jones gets a chest x-ray when she comes into your office and still has a quality outcome, whether or not Mrs. Jones gets that chest x-ray ought to be of no interest to anybody. No interest to anybody, because we waste huge amounts of money. So we ought to use science to determine what quality is and to track what quality is. Third, flexibility is absolutely key. Flexibility in all areas. Patients and doctors ought to have flexibility to move in and out of the system voluntarily at their will. States ought to have the flexibility to create the kind of programs, especially in the area of Medicaid, that they believe are most appropriate. Licensure ought to be licensure ought not be tied to any plan whatsoever. State licensure for physicians ought not be tied to any plan. Physicians ought not be forced to participate in any particular plan. They ought to have the flexibility of their practice model. And finally, a couple cautionary notes on the proposal that will be introduced today. One, graduate medical education. There is no doubt that the graduate medical education system needs to be reformed. Without a doubt, it's utilizing a system now that does not work any longer. But I'm not certain that providing less money for graduate medical education is a step in the right direction. Many residency programs across this country train their residents in either tertiary care centers or in indigent hospitals that oftentimes have huge challenges in their patient population from a healthcare standpoint. And so to try to measure that solely on the basis of outcomes without, again, looking at the quality and who's defining that quality, I think is challenging. So every single patient, everybody in this room benefits from resident education in this country. We ought to look at a system that appreciates that and will recognize that and will fund it in an appropriate way. Second cautionary note I would suggest to you is the issue that I mentioned before, and that's the practice of defensive medicine, where we waste hundreds of billions of dollars every year. Any comprehensive program for health care that doesn't include lawsuit abuse reform, I think, is missing a huge opportunity, because it's through the decreasing the practice of defensive medicine that we're able to find the resources to be able to do what needs to be done overall in the area of health care. So congratulations to the folks who participated in this. It's a wonderful work product. I can't tell you how excited and enthusiastic I am about the minds that have come around to push this work product, because I think it's one of those things that will help create that critical mass to be able to move forward in a positive direction from a solution standpoint. Great work, and I look forward to the work ahead. So thank you so much. God bless.
Thank you. Dr. Price has indicated a willingness to entertain a few questions, and since I have the microphone, I'll go first, and then we'll turn to some of you. Don't worry, it won't be too hard. My question would be, Dr. Price, is in terms of, Speaker Ryan made that speech, whatever, 10 days or last week, I guess it was, saying, he really was committed to trying to pass a plan, as you indicated, in 2016. Is there any sense of what the process internally in the House will be to bring together the various? Will you just defer to the committees? Will there be a unified process across the committees? Is there any sense of how that might proceed?
Speaker Ryan has he's a creature of the committee process. He's not a creature of leadership, and he's not a creature of the political side. He's a creature of being. He calls himself a policy wonk, which is a good thing. And so he respects greatly the committee process, and I think that's what will be the folks that will be charged with coming up with the legislative proposal. And so I think primarily it'll be Energy and Commerce and Ways and Means Committee. Education Workforce, as you know, has a hand in it in the area of ERISA, but primarily I think it'll be Energy and Commerce and Ways and Means. And the committees, the folks on the committees, I can tell you, having had conversations with a number of them, and I serve on Ways and Means, we are enthusiastic about moving forward with a piece of legislation. And this is hard work, as you all well know. And even coming up with a proposal that can be embraced by folks from a legislative standpoint is a challenge. But I think that we'll be able to do it.
Great, thanks. I think this gentleman here was first, and I'll come back to the others.
How do we incentivize? Excuse me. Thank you, Congressman.
Yeah.
How do we incentivize some of the best practices that are going on? And I'm thinking of the state of Washington, which for a number of years is tracking outcomes in hospitals. And for example, Intel, which is a big employer and self-funds its health care, is funneling their patients, actually telling them where to go for heart surgery, et cetera, as opposed to the government imposing fines on discharge, which hospitals have little control once the patient leaves the hospitals. Are we sending the wrong message, and how do we incentivize best practices?
No, you're absolutely right. We are sending all the wrong messages right now, and you've got a federal government that believes that it knows best about health care and is incredibly prescriptive about what needs to be done, not just in this area, but across the horizon of health care. So the way that you incentivize best practices is to put in place a system, a policy that actually incentivizes and rewards best practices that work. So you get back to the issue of flexibility. Systems, patients, physicians have to have the flexibility in the law itself to be able to do what is best. And what's best in January of one year may not be what's best in November of that same year. And government is absolutely incapable of recognizing that, and therefore the prescriptive nature that government utilizes in healthcare is anathema to the kind of innovation that's so necessary in the area of healthcare, which is so very, very personal. So the system has to incentivize that and reward it.
Next question, Gail.
Do you anticipate that the House will be able? Oh, I'm sorry. That the House will be able to come to a single policy package with the Senate in the course of a single year like 2016, or would you regard it as success if the House can forcefully get behind a plan and push that forward?
Yeah, having
This is asked of a House member. Yeah.
That's right. Having worked with my Senate colleagues diligently to work to get the first budget that balances within a 10-year period of time in 14 years through the House of Representatives together, I think it is highly unlikely that the Senate shares our enthusiasm in putting forward legislative proposals. Now, that's not to say that they aren't interested in solutions, because they are. But there is a mindset in our sphere that says that until you have to make difficult decisions, you ought not make difficult decisions, because politically it may be challenging for some folks. I'm of the belief that, and I share the belief that Speaker Ryan does, and that is that unless you make legislative decisions and put forward the positive solutions that we have, then the American people look up here and they see fog. They don't see any difference. There's no contrast between the visions that we have. The people who put this policy in place that we have right now, many of them firmly believe that this is where these decisions ought to be made, that the federal government ought to be making these decisions. We simply believe that that's absolutely wrong and violates, again, the principles that the American people want. We believe that these decisions ought to be made by patients and families and doctors. And so we ought to put forward a legislative solution that embraces that principle. And when we do, then the American people can say, those are the folks we want to be with, or these are the folks we want to be with. And I'm happy to have that discussion, that debate, and I'm very confident in the outcome of that debate if we put forward these positive solutions.
I think this gentleman here was next. Please wait for the microphone, and I forgot to mention, identify yourself if you can.
My name is Bruce Smith. Just had the question, Congressman. Thank you for your observations and analysis here, but I just wondered, is striving for a proposal a bridge too far, and would it be more practical to say break this up and have one measure on manpower, graduate medical education, one, and then a bill on tort reform, and then maybe then a bill on pooling of risk pools and so on, rather than one kind of overall package solution?
Yeah, no, it's a great question. It's a question of tactics. Whether or not it's a single legislative bill itself, whether or not it, so that you can stack it up here and say this is it, or whether it addresses all of the issues in healthcare that need to be addressed with legislative solutions, I don't feel necessarily strongly about. But it's important that we have legislative solutions that are out there that are embraced by all, so that, again, we can provide that contrast. I do think it's important, however, to have a package that addresses all of the challenges that we've got, and the package that you've got before you today does just that. It addresses Medicare, it addresses Medicaid, it addresses the private market, it addresses the VA system. So I think that as long as it's not legislative language, I might add, because that's a challenge. But as long as we're addressing all of those areas, whether or not it's one bill or whether it's 4 pieces of legislation, whatever it is, I don't feel strongly about it.
I think we have time for one last question over here.
Hi, my name's Danielle. I'm an OR nurse for 28 years. Recently,
And orthopedics was the best, was it not?
I did open heart surgery,
All
sorry.
right.
But I did do a year of orthopedics. My son had ulcerative colitis, and being as a nurse and a mother, I've been on both sides of this situation, so I feel like I've gotten a new look at some of this. One of the things with ulcerative colitis is you have to choose either to go a surgical route or a drug route. And there is basically no guidance, I felt, from the medical field on this. And how do you go to your 20-year-old when he was diagnosed at the time and say, hey, just get the surgery and be over with it, especially since I've done surgery for so many years and I know all the risks and seen where if you don't have the correct people, what happens. However, when you get the bills and you realize that Remicade, when you start Remicade, it's $11,000 every 8 weeks for the rest of your life. So it's simple math. Mm-hmm. He eventually got, the Remicade didn't work, and he exacerbated, and due to some bad decisions, ended up with an emergency surgery. Basically, the cost of the surgeries, the 2 surgeries that he had, was $66,000, of which the insurance covered $18,000, because he ended up going home with wound vac and MRSA and the whole 9 yards, and the mother ended up packing 4 incisions. If
we could get to that's not a question.
as far as look, you said about bringing everything together, there is no. I mean, the cost of what he could have been was what 1 year's surgery covered, and it was. There's no camaraderie on the medical field even. So how does the insurance company? No one works together to determine what's the best practice.
Let me and God bless you for the ordeal that you and your family have been through. It's these health challenges are incredibly real. They're incredibly personal. And that's why the nexus or the genesis of the decisions about these things ought to be personal, and the flexibility needs to be there. Let me ask you to imagine a system that's not like the one that we have right now, nor like the one that we had before Obamacare was put in place. It's a system that actually provides incentives for the kinds of solutions that put in place best practices, that allow specialty societies and physicians to be able to access the kind of information that they need clinically, medically, in the science, in real-time basis, that incentivize that kind of system and make it so that you and your family have the opportunity to go where you want to go and need to go to be able to access the care that you need. And let me ask you to imagine a system that actually has cost controls, because you've set it up in a way that incentivizes the most efficient care, the highest quality care at the least expensive price point. The way that you do that is not to have the federal government dictate what things cost. The way that you do that is to recognize that the cost drivers in healthcare are the same as in any other business in this country, plus one, and they're taxation and litigation and regulation. Plus the lack of competition. There is so little competition in the area of healthcare that our costs continue to skyrocket, and medical inflation, as all of you know, outpaces regular inflation year after year after year after year. And that's because we don't address the real cost drivers in healthcare. The two biggest, I believe, are regulation and the cost of defensive medicine, which drives up everything. So if you had a system, imagine a system that actually puts the authority and the power and the opportunity and the flexibility with those that actually need it, then over time you'll get to a point where people have a higher quality of care and a higher satisfaction with the system than we currently have. So, thank you all.
Thank you very much, Dr. Price.
Thank you. Thank you. Take care.
Great. Thank you very much. Really appreciate it. Good. Okay, thank you very much. That was terrific introduction to our session this morning. I think now we'll go ahead and get to the proposal itself. I'll make a short presentation, this overview of what we've proposed in this plan, and then, as I indicated earlier, after I'm finished, we'll have Joe and the panel come up to the dais here, and they'll have a discussion about various aspects of it from their own perspectives. So why are we here this morning? Again, it is to discuss this plan that we released today, Improving Health and Healthcare, an Agenda for Reform. As I indicated at the very outset, this is a plan that has 10 co-authors, myself and 9 colleagues that I was very, very pleased to work with. It is a I'll mention them all by name: Joseph Antos, my great colleague here at AEI, Lanhee Chen, Scott Gottlieb, Yuval Levin, Tom Miller, Ramesh Ponnuru, Avik Roy, Gail Wilensky, and David Wilson. They all contributed very substantially to the development of the ideas in this plan. But I do want to start by noting that for those of you that follow this debate and have watched it over the years, you might see a lot of familiar ideas. And in fact, many of the ideas have been advanced by folks at AEI literally for decades in various ways and pieces. What maybe is a little bit unique about this is that the plan has pulled together reform ideas across the spectrum, as Dr. Price was alluding to in his comments. We covered most areas of financing and delivery system issues in the health system. And we do it across, the big payment programs. We have entitlement reform in this plan, and we have a perspective that is focused on innovation and improvement in the health system over time. So it's fairly, as he indicated, maybe this is not a great word, and maybe some people view it as a negative, but fairly comprehensive in the sense that it does try to address many aspects that are part of the reform agenda. The second perhaps unique aspect of this particular effort is the number of co-authors, right? So the exercise really was to try to bring a number of people fairly like-minded together around a single reform structure and framework, in part because we all recognize we're at a little bit of a unique moment. A big plan was passed in 2010. Many of us are slightly uneasy with that plan, and so nothing focuses the mind a little bit like, the prospect of everything going in a direction you're not altogether happy with. And so if there is going to be a movement toward a less regulatory, less federally run, less micromanagement from the HHS bureaucracy type system, it seemed to us that now's the time to really start pushing for it, because there's a fair amount of momentum, frankly, in the other direction. And so there's a certain urgency about this, and we wanted to put forward a plan that, because we have all in our various ways expressed some unease with the current trajectory, we felt a little bit of an obligation to put forward a concept of how we would do things differently. The way we went about the work was to first develop a series of, as always, principles, and built the plan around those principles. They'll be quite familiar to you. I'll articulate them in just a second. And then went forward with applying those principles across broad areas of current financing and delivery system issues. The principles that we settled on were as follows. This is a summary of them. You can read the report to get more of a flavor for how we articulated them. But the number one principle is what Representative Price emphasized in his plan, and very much is the animating principle behind ours as well, which is that we really believe that ultimately, over the long run, and these questions are really long-run questions, that control of resources in the health system is best left as much as possible in the hands of consumers deciding where to allocate the resources in the health system, and not so much the federal government or government doing it centrally. I think if you were to look at healthcare policy over the last half century, maybe even a little bit more, the general push and movement has been toward more and more federal control of the resources through both taxation and subsidy structures as well as regulation. And there's been pushback in a number of areas toward more consumer control and influence. We think that much more of that needs to take place, and then that becomes the central component of how things are designed moving forward. The second big principle is defined contribution payments. This is related to the first, but there is in existence a very large apparatus of subsidies going to consumers of the health care from the federal government mainly. And to have a true market-based, consumer-driven system, we would recommend that most of those be restructured as much as possible toward defined contribution payments. That is, that there's support for people enrolling in health coverage and accessing the services they need, but that amount of the support they get leaves some discretion on their part to make decisions about the kind of care they get and the cost of it. And so that the consumer is more involved in value judgments about the best use of the marginal dollar. A third major element in terms of principles was decentralization of power. There's always been an argument about the Affordable Care Act and what its main purpose was, and a lot of times it's been argued that actually, it adopted consumerist market-based principles. And of course, there's an element of truth to that. There is an element of consumer decision-making in the Affordable Care Act. But if you actually get into really what the main thrust of the bill is, it really was to move a great deal of power and regulatory authority from individuals, employers, and states to the federal government. And so the federal government now has a massive, massive amount of power over the health system. It has pretty much carte blanche power over the insurance system, some of which it hasn't utilized yet. but which it could in the future with very open-ended delegations of authority to the Department of Health and Human Services. And in the Medicare program, there's a huge amount of authority to regulate the actual delivery and practice of care. And so really between those two things, the federal government can really dictate the terms of the health system through additional regulation. My own view is that when power, through a lot of evidence over a long period of time, when power has been delegated to big federal bureaucracies, they rarely give it back. Moreover, they rarely fail to exercise and utilize it to enhance their power and position over time. There's a natural cycle to these things with federal bureaucracies, that they get some power, then they figure out how to utilize it to make sure that they maximize that power and retain it over time. There's a long literature about this concept. And so this massive delegation of authority to the federal government is likely to lead to much, much more federal regulation and control over time if left as it is and unchecked. Fourth, deregulation to allow medical innovation. We believe there needs to be much more space for the introduction of new ideas, new ways of practicing medicine, new ways of taking care of patients that doesn't bump up against so many of the payment and regulatory barriers that are in place today. We are in the middle, probably at the very early stages of a massive information technology convergence with medical practice revolution. Okay, so the ability to figure out the best ways to take care of individual patients, prevent them from getting sick, prevent cancer, prevent some of the most costly and difficult conditions that afflict people, the convergence of very sophisticated information technology, which with advances in medical knowledge is really on the cusp of huge new breakthroughs in these areas. And we want that. So we want to encourage and allow that to happen. That's what patients want. That's what the American people want. But you have to have the ability to introduce it, have people pay for it, and have incentives for people to do the research, figure out the hard work of actually changing processes to deliver that kind of care to patients. All of that takes money, time, investment. You need to create the space to allow that to happen. And then the fifth area principle that we really spent a lot of time focused on, which was, my background is in federal budgeting, as is several of my colleagues on the report, and we really believe that our nation has to get its fiscal house in order, especially over the medium and long term, and that entails really rethinking and reworking many of our health entitlement commitments, not just health entitlements, but other entitlement commitments as well. But this report is focused on health care, and so our plan really has a focus on making sure we do the changes that are necessary to reduce the pressure associated with long-term health entitlement spending. I should note on that point that as part of the project, we did have the plan reviewed and estimated by an independent organization. The Center on Health and Economy has a modeling capacity to look at these kinds of plans and has done so on many occasions over the last couple of years with various plans. We had our plan looked at. That cost estimate has also been made available today at the Center on Health and Economy website. I won't spend a lot of time talking about it today. You can review that plan on your own. It speaks for itself. But suffice it to say that we meet many of the objectives that we want to meet with the plan, according to this estimate. It covers many, many millions of Americans with health insurance. It allows for more innovation and more flexibility in the health system. It reduces expenditures and reduces commitments to bring a lot less budgetary pressure in 10 and 20 years' time. And it does so in a way that brings just as much security as the Affordable Care Act, at least in our view, in terms of accessibility to insurance as well as care. Now let me just talk briefly about the structure of the proposal itself. There's many proposals in the plan. I won't try to cover them all in the time here. The panel can cover some of the issues in more depth when they come forward. But I thought I'd better at least try to give you a little bit of a structure of how it looks and what it's about. The first component of the plan is, of course, replacing the Affordable Care Act with an alternative approach. It has a couple of important features associated with it. The first is the retention of the employer-based health insurance system. I know that might strike some people as a little bit of a status quo principle, but in some sense, I do think it's important to state this up front and be clear about it, that the United States has a big, vast, and fairly robust employer-based health insurance system. 155 million people or so get their health insurance through employer plans. It does not, it is not wise to start a plan, in my judgment and our judgment, by upending all of that all at once. And so our first principle actually really is to say we are largely going to leave that employer structure in place with one proviso associated with that, which is we do believe it needs some cost discipline. And so instead of the Cadillac Act, which is part of the Affordable Care Act and now bipartisan displeasure with, the proposal would have an upper limit on the tax preference for employer-based health care, set at a fairly high level, not as high as the Cadillac tax, but fairly high. And that would allow for additional discipline on the system. The only folks who would end up paying more in terms of revenue associated with that, well, not the only people, but the way it works is slightly more progressive than the Cadillac tax, because when you impose that kind of an upper limit and someone exceeds it, the taxable compensation is higher for the tax consequences more for people in higher tax brackets than lower tax brackets. So we believe it's a more progressive way of applying some cost discipline to the employer system. Second big component, of course, is something Dr. Price mentioned, which is refundable tax credits. We embrace that in this plan. We believe that for those who are outside the employer system, they should get essentially a roughly comparable tax credit that's equivalent to the tax preference that the other folks get through employer health care. That seems to be fair and equitable. And candidly, if you don't do that, it's very difficult to see people of modest means being able to afford a reasonable plan, especially even for catastrophic insurance coverage. So we do support a uniform refundable tax credit approach for people outside the employer system. A third big area in this part of replacing the ACA is something that might be called continuous coverage protection. It's a regime of insurance regulation that essentially says as long as someone stays insured, at least with catastrophic insurance protection, that their health status, much like the Affordable Care Act, can't be used to to adjust their premium, the coverages that they're offered, or the offering of coverage by an insurance plan. So as long as someone stays insured, they're protected from their health status changing, having an effect on their ability to get the same health insurance that they've always gotten. Now, one other last element here is there's an emphasis on transition. The Affordable Care Act's been in place now for, it's going on its second full year of real implementation. Next year will be its third full year of implementation of its major provisions. That means that lots of things have changed and been built up around it. One cannot ignore that. I don't think it should be ignored. And so we believe that when you put something in place that might move in a very different direction, you're going to have transitions. You're going to have the ability to move people from what they've been put into this new program somewhat moderately over time. In general, I think that means essentially grandfathering people. That is, people that are on the current subsidy structure or on the current Medicaid expansion, they're not going to be pushed out of what they're in today. There's going to be a natural cycle of movement from current rules to new rules as those are put in place. On the Medicaid program, we recommend essentially thinking of Medicaid as two parts. There's a big part of Medicaid which is the elderly and disabled. Actually, most of the spending in Medicaid is for people that are disabled or are over the age of 65 and use Medicaid in addition to Medicare. This is a very, very expensive and costly part of Medicaid. It's important. It provides an important safety net for millions of people. We largely think, though, that is how to reform that is separate and apart from many of the reforms that are associated with delivering health insurance to people for acute care health care that everybody in the working age population tries to secure. So we believe that you should divide Medicaid's reform really into two parts: provide per capita payments from the federal government to the states with maximum flexibility for addressing reforms to these two different populations. And then for the population that is able-bodied, as well as children, parents and children, as well as able-bodied single adults, the states would receive per capita payments from the federal government, and they would have maximum flexibility to integrate that Medicaid component with the larger insurance reform that's been described as part of replacing the ACA. So the hope there is that states would be able to use Medicaid as a supplement to the federal tax credit and allow people to secure more mainstream insurance that allows them, as their earnings go up, to stay with the current coverage that they secure just through a regular federal tax credit. Medicare. Medicare, of course, is a huge part of any kind of reform agenda. It's difficult to imagine a package that has replacing the ACA but also takes on Medicare. I mean, there are such huge issues, but in a certain way, unless you address Medicare, you aren't necessarily reforming healthcare, because Medicare is the dominant payer in most markets. Its regulatory structure really is the most important factor in deciding and determining how physicians and hospital systems set up their structures to take care of patients. It's not the only factor. It's just the biggest and most important. Its regulatory regime really is pervasive and dominant. And so if you want to move the health system toward more efficiency and higher quality over time, it's difficult to imagine that occurring without some effort to think about Medicare's role in that larger structure. We, perhaps not surprisingly, endorse the concept of premium support, which is really the notion of bringing a competitive bidding and market-based competition approach to the Medicare program over time. This would be done on a prospective basis for new entrants into the program after about a 3-year period. And they would be allowed to pick the traditional Medicare program as one of their options. So the traditional program would compete with other private offerings. Medicare beneficiaries would get a defined contribution payment based on the bids that come in from the plans and would be allowed to select which coverage option they want. This is a way to bring into the larger structure of Medicare some of the same dynamics that I believe have played out very well or better than many had hoped in the Medicare drug benefit that was implemented over the last decade. A second major component of this is to modernize the Medicare benefit structure. Medicare was created in 1965 with this notion of a hospital insurance and supplementary medical insurance, 2 separate deductibles, separate cost-sharing structures. It makes no sense the way it's structured today. And everybody, many people on both sides of the aisle, believe it's time to modernize the benefit structure so it has some rationality to it as a coherent insurance product. That needs to occur. We would recommend doing that as well. We also believe that beneficiaries should be allowed to elect and opt into some kind of new integrated care option as part of the Medicare program. This would be within Medicare's traditional structure and would be a new option within it. In some ways, this would be a replacement for the concept of accountable care organizations that's been promoted since the ACA was enacted in 2010. The concept here really is that the ACO concept of accountable care organization, I think, has one big flaw, which is that the beneficiaries really are left out of the equation. It's a shared savings program between the government and the provider community. But the way the beneficiaries get into this new integrated care option is through what they call assignment. Basically, if the physician is part of the ACO, then the beneficiary is part of the ACO. They don't even really know they're in it. And in some sense, that's the sort of the opposite philosophy of how we'd like to build our approach here, which is to have the consumer say, yeah, I'd rather get my care through a integrated care option. By so doing, I get a lower premium, and I get more organized care, and it's better communication and less fragmented and more clear. If that's what occurs, it's a benefit for all involved. So we want to push for that kind of an approach within Medicare's traditional structure. Lastly, I'll talk briefly about this another major structural component here, which is what we think is very important, is to promote lifelong enrollment in health savings accounts. Health savings accounts were put in its current form in 2003 as part of the Medicare drug benefit legislation and have really taken off in the country. There are many millions of people now enrolled in HSAs, mainly through the employer sector. You do some analysis of how they are working in real practice at this point. They seem to be working on both levels, trying to control costs as well as satisfaction with them by the enrollees themselves. And what we'd like to see is much more universal enrollment in HSAs across the board in the United States, especially as there is a move toward additional cost sharing and higher deductibles, that people will want to have control of some of the resources below those deductibles and know that they have the ability to pay for care, and that judicious use of those dollars can accrue to their benefit over the long run. And so the concept really works, and what we need to do is keep building upon the progress that's already been made and make it more universally available. So the proposal would try to incent more universal enrollment in them, try to break down some of the barriers to them, one of them being that we would allow people to make contributions to an HSA even if they have a relatively low deductible, lower than the current statutory requirement. Right now you have to have a deductible of a certain dollar amount before you can make an annual tax-preferred contribution to your HSA. We would allow people without that kind of a deductible to do so. Of course, you know, HSAs are really not for 1 year at a time kind of spending. The whole concept is to accumulate resources over many years. And so it doesn't really make sense for someone, even in the years when they might have a relatively modest deductible, not to be able to save for future contingencies. So we want to have much more universal enrollment in the HSA program and would allow that to occur through that approach. We also believe that HSAs, the actual HSAs you have when you're in the employer sector, should be allowed to be carried into Medicare and used in your Medicare benefit. And we'd like to see it much more common and robust approach in the Medicaid program. Right now, the state of Indiana is testing out an HSA approach, has been for several years now. They're going much bigger currently in terms of using Medicaid with a higher deductible insurance plan plus an HSA type account for paying for care for lower income households. So we believe building upon that HSA approach is very important. My last point will be to partially disagree with Dr. Price. It wouldn't be great if we were all agreeing about everything today. So, you know, our view on the graduate medical education is we've been down this road for decades. Okay, the federal government's been spending billions and billions and billions and billions of dollars on the supply of physicians into the medical system. And comprehensive reports have been done intermittently over the years. The latest one by the Institute of Medicine pretty much all conclude that there's no real connection between the federal dollars spent and the quality of the physician corps. And so it's makes you wonder exactly what we're up to here. And we would like to see a major reform of the program that downsizes the federal role. I do believe physicians will still be trained and still go into medical practice, even if the federal government wasn't spending all of this money that's mainly going through institutions, even as the practice of medicine should probably be going more into an outpatient setting. So we do propose a major reform in that area. We propose many other things that are not on this one-page summary chart, and I hope the panel, which will start right now, will cover some of them. Thank you very much.
Hey, Lynn, how are you? Good to see you.
Good to see you. How are you?
Can't read that, but is that?
Is that you? Yes. Yeah, that's you. Do you know what's going to be discussed next week? Did you send it to me?
I sent you.
Okay.
It's annoying.
I'm not sure I looked at it anymore, but if I had a chance, I'd get it.
Okay, well, thank you very much. Thanks, Jim, for that brief summary. We Those of us who worked on the project, at least I, appreciated being reminded what the report's all about. I'm particularly grateful for Dr. Price coming today to heap praise upon our efforts. But I was disturbed that he did locate our GME recommendation. We buried that at the end of the report. So disturbingly, that probably means he actually read it. Of course, GME is near and dear to his heart. One other comment about something that he said. He mentioned tort reform and defensive medicine, and his points are well taken. But clearly, it's not just the threat of a potential lawsuit that drives much of the inefficiency in healthcare today. It also has something to do with the way we pay for healthcare and the choices or lack of choices that we give patients, providers, employers, and insurers. In other words, everybody. It's the system. What was our objective in writing this report? I would argue that, at least in general terms, we wanted to start from where we are, not from where we want to be. I think this may distinguish our plan from many other plans that kind of jump to the conclusion that you can instantaneously transform a very complicated and messed up system into something ideal immediately. We have built in transitions. And I think, the fact is that we were also trying to come up with a plan that could be scored and that would have effects in the first 10 years. For me, the idea of such massive changes, those are good goals, but the idea that you're going to get everything done within a few years, within 10 years, I think is wrong. I think the Affordable Care Act demonstrates that you're just not going to be able to make those changes in the way you think you're going to make them when you pass the legislation. But if you give yourself time, if you recognize that the things that you started out to do might not be completely correct, or that there might be some new information that you didn't have, that, to me, is the way to a sensible reform of the healthcare system. Okay, so I like to draw everyone's attention and give a shout out to Health Affairs today. A blog posting that the authors put up today. It's not 70 pages; it's 4 or 5, I think. I highly recommend that as an alternative to actually reading the report. I know I appreciated that. And then I guess finally, I want to thank Jim Capretta. Jim organized this project, and that took an enormous amount of effort, an enormous amount of patience, and incredible good sense in his selection of co-authors. I congratulate him on that in particular. So he brought us together on this, but that doesn't necessarily mean that we all agree on everything that's in the report, as I think you may detect on this panel. Let me just mention the lineup of the speakers. We're going to start off with Lanhee Chen. Really appreciate Lanhee being here because he took a red-eye flight from California, and you look remarkably alert.
I was going to say, don't hold me accountable for anything I say this morning.
Okay, very good. Then Scott Gottlieb from Lanhee Chen is at Stanford University. My colleague Scott Gottlieb, a physician, but we'll forgive him, will speak next. Then Gail Wilensky at Project Hope, third speaker. Then Tom Miller, my other colleague on the panel at AEI. And then finally, discussants who may not completely agree with everything we have to say. starting with John Holohan at Urban Institute. And I particularly want to thank John for filling in at the last minute. If you saw the original invitation to this, Bob Reischauer was going to appear, but something came up. He couldn't make it today. So thank you very much, John, for coming in. And then finally, wrapping it up, Chris Jennings. Now, what we're going to try to do is have relatively brief statements. People will, contrary to Jim's promise, we will not be discussing necessarily the details of particular chapters, but we will be talking about issues that are particularly important that resonate with each of us today. And then after the brief presentations, we'll have a little argument among ourselves, and then we'll get to, discussion. And then we'll go on to questions from the audience. So with that, Lanhee, please take it away.
Well, thanks, Joe. It's it really, to Joe's point, it really has been a great pleasure to be a part of this group. And if any of you saw how well Jim kept us on timeline, you would be impressed. Also, if you saw, if any of our emails ever get subpoenaed relating to
It's great, Lanhee.
our discussions, they are very amusing. So maybe someday we'll write a book about it. So I just want to make some very general comments about where this plan sits with respect to the broader debate about health reform. And I think actually the plan comes at a very opportune time because in a lot of ways, what we're seeing is even though the Affordable Care Act is 5, almost 6 years into implementation, there remains a significant amount of disagreement over it. And more so, there remains disagreement regarding what might take its place or what elements might take place of its elements. And so I think that our plan certainly reaches consensus on a number of issues. I think that consensus is fairly close to where a lot of people who believe in market-based reform of the healthcare system, I think a lot of the points that we raise come pretty close for people who believe in those basic principles. But I just want to raise 3 points about where I think we are. First of all, I think some of the policy shortcomings, and I mean specifically the policy shortcomings as opposed to the political shortcomings of the ACA, have become quite plain over the last several months. I think particularly with respect to a lot of the coverage around the structure of the ACA. And some of the failings we're seeing, whether relating to rising premiums, lack of access to physicians or medical facilities, structure of plans, the participation or lack thereof of certain insurers, all of these issues are related to structural shortcomings in the ACA. And as a result, the call to completely repeal and replace the ACA is not simply a political battle cry. Indeed, it's much more than that. It actually speaks to what we as, I think, co-authors believe are shortcomings in the way the law is structured and therefore a need, as Jim alluded to return to first principles, which we believe are very different from the first principles that animated the writing of the ACA. And so the structural problems are things that I think we've tried to address. If you look at our plan, there is, for example, an emphasis on a return to state control in many ways. There is an emphasis on the importance of consumer-directed health care, the relationship between patient and doctor, all of those things which we believe the Affordable Care Act has taken us away from, we believe that our reform takes us back toward. Secondly, I think that notwithstanding some of the political dialogue, health care remains an issue that people care about. And the ACA remains broadly unpopular for some of the reasons I articulated earlier, but also because, I think a lot of people 6 years in still don't have a great sense of what it is the law does. And so I think part of our goal was, again, to return to some very basic principles that we believe are easily articulable and express a point of view that is closer to a system that is consumer-directed and market-based as opposed to one that's centrally controlled and further exacerbates the distance between the end consumer of health care and the payer of that health care. Finally, I guess in terms of a macro point, I think part of the challenge that Republicans have had, and this is probably more of a political point, is that they've been unable to coalesce around a single plan set of reforms to replace the Affordable Care Act. And so as a result, the tendency in the media in particular has been to characterize the Republican position as just say no, when in fact there is actually a large variety of ideas out there about different ways to incentivize health insurance coverage, different ways to address the problem of pre-existing condition exclusions and coverage for people that have pre-existing condition exclusions, the problem of how to deal with the tax exclusion, on down the line. There are a lot of ideas out there. We articulate some in our plan that we believe are fairly, we believe quite sensible and represent that consensus view. But it's important to realize that the status quo ex ante was unacceptable. The tendency is also to characterize the view that because we don't believe the ACA is the right answer, we want to go back to a system that frankly was badly in need of reform pre-ACA. And so I think our plan provides important leverage in the discussion over where the system goes from here, and in fact, ways that we can improve upon the system rather than simply returning to a system that everyone agrees wasn't quite working the right way before. And so part of the goal here is to arrive at consensus and is to arrive at a plan that we think the vast majority of people who are looking for market-oriented reform can get behind, but also to provide some estimation of what the plan will do, which to Jim's point, we have the Center for Health and Economy that have done a great job of estimating what we believe the effects of this will be. So those are just some basic points. Why don't I just cede the microphone at this point? I have some more stuff about the plan specifically, but in the interest of time, I'm sure we can get into that later on.
Great. Great, thank you. Scott, take it away.
So I want to talk about some of the medical practice aspects of what we envision. And in particular, I want to distinguish between what we envision under this proposal and the types of plans that are currently available under the Affordable Care Act. There is a general refrain that the plans available in the Affordable Care Act are the sort of high deductible, consumer-driven options that conservatives call for, and that's simply not true. It's true that the Obamacare plans are very high deductible plans, but they offer an increasingly constrained benefit when it comes to choice of providers and drugs, and that's not what's envisioned under the conservative proposals, and it's not what we envision being the predominant kind of offering in the marketplace under this plan. A true consumer-driven health plan might have a high deductible to invest consumers in the cost of their health care decisions, but it would give consumers presumably a wider choice of providers and health options and drug formularies to allow them to make decisions that ultimately lead to optimization in the marketplace. And that's why when you look back at the consumer-driven health plans that became more prevalent in the early to mid-2000s, when there was a push to try to incentivize the development of these plans, they were often coupled to PPO-style networks and formularies that were far less restrictive than the Affordable Care Act. And to give you an example, I'll take up a topical issue, which is drug costs. There's obviously a growing refrain that people are being saddled with very high drug costs, and there's been an emphasis on the cost, the list price of prescription drugs. But when you look at the actual cost growth in drugs, the net price, it's actually quite low relative to historical years. Inflation last year ran at 5.5%, the real effective price of drugs. But that's not to say there isn't high-priced drugs and there isn't a problem. It's certainly the case that there are generic drugs, old generic drugs, that are inappropriately priced high because of failings, I think, in the generic drug approval process that prevent competition in those categories. And there's certainly cases where there's orphan drugs that are delivering exceptional value but are priced very high. But if the overall price increase of prescription drugs is running at 5.5%, what's going on? What's going on is that the structure of insurance coverage has shifted dramatically, where you're seeing far more prevalence of closed formularies and very high deductible plans coupled to very high coinsurance, where consumers really are underinsured for drugs. And when their drugs don't fall on their formularies, they have no coverage at all. So this is a relatively new phenomenon. We've seen closed formularies in the market before in the Medicare program, but the Medicare program had a lot of regulation, protected classes, other things that made sure important drugs were on those formularies. Now we're seeing closed formularies where consumers are completely uninsured for drugs that don't make their formulary list, and very narrow formulary lists. So important drugs don't get on. And what you pay out of pocket for the drugs, if they're not on your formulary list, don't count against your deductible and don't count against your out-of-pocket maximums. And so this is what has changed most dramatically in recent years. It isn't the cost of drugs, which continues to go up, and there are pockets of hardship, and there are pockets of inappropriately priced drugs, but what's changed most dramatically is the structure. Now, it's not that insurance companies are doing evil things. They're playing within a very constrained set of rules and doing whatever they can to try to control costs, because all the traditional tools that insurers use to try to manage costs, changing benefit design, changing premium structure, have been taken away from them because of the heavy federal regulation. So all they can do is try to constrain utilization. The only way to constrain utilization is to constrain access. And so they're coupling these high deductible plans with real constraints on access. I have a piece up on Forbes today, not to plug my own copy, content on data when we're releasing sort of shared content, but I'll do it nonetheless, where I look at just drugs for multiple sclerosis, and I'm going to put out more detail on this next week. But I looked at insurance plans across 5 states. I looked at silver plans in the most populous county within 5 states, and looked at all the offerings within those counties. And what I found was very discouraging. I'll just read you some of the results briefly. I looked at 20 different plans across these 5 states. One of the insurance, so I looked at how they covered multiple sclerosis. And the reason I focus on multiple sclerosis is because it's a disease where it's kind of why you buy insurance. You insure against catastrophic risk like that. And it's also a disease where drug selection is very important. Patients get a real differential response to different treatments with that disease. And if you're on one drug and controlled, you don't want to be switched off of it. So of the insurance plans, one covered 11 of the drugs. I looked at the 12 most common drugs for treating multiple sclerosis, both injectables and orals. 3 of the plans covered 10 of the 12 drugs, and 4 of the plans covered 9 of the drugs. Aetna on the whole, incidentally, was the best insurer, not to plug Aetna, but just revealing the truth of the matter, across all the states. Of the remaining 12 health plans, 3 covered just 8 of the drugs, 3 covered only 7 of the drugs, and another 3 covered just 6 of the drugs used to treat the disease. And of the remaining 2 health plans, one of the plans only provided coverage for 4 drugs, and the final plan only provided coverage for 3 drugs. What's important is these were closed formularies. So if your drug didn't make it on a formulary list, you didn't have any coinsurance. It was always common in the insurance market, you had coinsurance, so costs were partially covered even for non-formulary drugs. In these plans, you're completely on your own. Everything you spend would be out of pocket, wouldn't count against your out-of-pocket maximums, wouldn't count against your deductible. Clearly untenable. Now, all the plans had appeals processes to try to get drugs on formulary if you absolutely needed a drug, but that is oftentimes not successful. So back to my main point, the Obamacare plans aren't consumer-driven health plans at all. They provide first-dollar coverage for a lot of real disparate mix of sort of politically favored health care products and procedures, and then they, in many cases, provide very skimpy coverage for everything else, including catastrophic health care costs associated with serious illness. A real high deductible health plan, what we envision under this, would preserve choices so consumers should shop around for lowest cost, highest value options. That's how it leverages market principles to improve efficiency. I think the Affordable Care Act, because of all the very odd restrictions, regulations, and federal controls, really constrains choice as a top-down means of cost control. Obamacare is not a consumer-driven high-deductible scheme. It is simply a high-deductible scheme coupled with increasingly hollowed-out coverage. So just to close, we envision something very different, and I think we need to be careful with the lexicon here because of the fact that the Affordable Care Act has high-deductible plans, they've been perceived as consumer-driven plans, but a consumer-driven plan isn't merely a high-deductible plan. It's a plan that couples involving consumers in a lot of the first-dollar choices that they make with flexibility to make choices that lead to optimization in the marketplace. Thanks.
Thank you, Scott. Let me just add one other thing to add to the idea that this is a truly consumer-driven approach. The health savings account expansion, in particular, if you have the opportunity to also put money aside or get a subsidy that puts money aside for you, that helps with the high deductible. And of course, that's not available under the Affordable Care Act. In fact, the ACA limits the use of HSAs. Okay, I think next, Gail, please. Thank you.
Thanks, Joe. I'm going to make a few points that, of course, have already been made now by various speakers, but I think we can't emphasize too much the notion that we do not accept the pre-ACA as a point that as a goal or a place we want to return to. The notion of getting coverage to more people is important. We think that, I personally think it is the best part of the Affordable Care Act, that it has expanded coverage. Although I think there are a lot of other aspects of the Affordable Care Act that could be done differently, and that really is the point of this effort. The fact that there are a number of us who are across a spectrum within the center-right conservative spectrum, I think is also important in that we're able to come together and indicate that there are many policy changes that we agree with. Of course, as in all joint efforts, not all of us agree with everything that's in here, but enough of what is in here that we both contributed to it and wanted to be a part of this activity. There are some themes that ought not to sound new because they have been present in many Republican proposals across now, as I think Jim indicated and also Tom Price indicated, a couple of decades. But let me just remind people what some of those are. The biggest, of course, is premium support. This is an issue that has been discussed for at least a couple of decades. There's something amusing, of course, that we have a current version of premium support in action. It's called the exchanges. Not a lot of people want to discuss it. I happen to be a Republican that's quite comfortable saying that. Not only is this a form of premium support, but actually the subsidy is calculated in a way that at least uses some of the words that have been used in some of the premium support proposals for Medicare. That is, it's based on the second lowest cost of the silver plan in an area. The place where there may be some significant differences is how regulated what's offered in the exchanges are. And a lot of the difference in what we have proposed goes to some of the points that Scott was just making, that it isn't enough to say that a plan with a high deductible is a consumer-driven health plan if, in fact, the components in the plan are not what somebody would choose. One of the reasons that you have seen such high deductibles, maybe questionably high for some of the people given their incomes, is the rather expansive benefit package they have been forced to buy, whether they wish it or not. The essential benefit plan covers a number of very expensive benefits, and therefore it is not surprising that you both see very narrow networks that have developed and also very high deductibles that have developed. These are all trade-offs, and it's one that we think is important to be reconsidered in trying to actually get plans for people that meets their needs better. The notion of refundable tax credits is also hardly a new idea. It has been an issue that has been proposed by various groups, especially those who are on the conservative or the R side, but not exclusively, particularly for people who don't have employer-sponsored insurance. And one that, when coupled with a tax cap on the employer-sponsored insurance, make the two worlds work together better than they may be working now. One of the concerns that has not yet been articulated frequently with the Affordable Care Act is that there are people who are in the low-income, low-middle-income range who may get very different subsidies depending on where they get their insurance. At some point, we may have to deal with this because otherwise you are likely to induce bad behavior, that is, behavior that will disrupt markets as people go to seek the best subsidy that is available for them. It's an issue that we have not yet taken on explicitly. There's clearly an attempt to move some of the very significant transition of power that has gone from what has historically been state-controlled issues to the federal government. This, like many of the issues that are included in the Affordable Care Act, is really worthy of discussion by the American people as to where they believe the nexus of power ought to lie. It has changed in a significant way, and this, among many of the issues that get raised, are appropriate for discussion. There's been concern raised about what happens to people who have pre-existing conditions. It's not surprising that we see here what has become a frequently discussed mechanism, in part, again, because like the exchanges, we have a real live example of how it can work, which is the HIPAA protection that is provided for people who are in groups of 2 or more, that if you maintain continuous coverage, that you are provided protection from pre-existing conditions. This goes a step further than the HIPAA protection, because it also indicates that you can't face discrimination in terms of pricing because of health status. I would argue that it actually is far superior to what the Affordable Care Act has done, because the Affordable Care Act completely unintentionally, by a combination of policy decisions, encourages bad behavior as much as it discourages bad behavior. And what I mean by that is having protected people from any adjustments in their pricing because of health status, have guaranteed them access on an annual basis to health insurance coverage, no matter what they have done in the past, does not really encourage the kind of good behavior it was intended to encourage. In fact, given the special enrollment periods that have been provided with each of the 2 existing years that we have had, and with the many large categories that allow people to jump in outside of those enrollment periods, we actually encourage bad behavior on the part of individuals who don't wish to have continuous coverage, but wish to have coverage when they have a need for it. And in fact, all of the major insurers have reported problems with regard to the special enrollments and the high risks that it encourages, or at least the major insurance companies have reported difficulties as a result of these special enrollment periods. As in many of the issues that we cover, we have attempted to show that the policy issue that was being raised in the Affordable Care Act was a real issue that needed to be addressed, but that the way it was addressed in the Affordable Care Act is not the only way it can be addressed. Probably as much as anyone, I have been long frustrated by the notion that there aren't alternatives to existing policy or to what we hear loudest being proposed. And I hope that people, when they look at the report that we have put out, recognize this as a serious attempt to take on the issues that have plagued the healthcare system both before the Affordable Care Act and sometimes even after or because of the Affordable Care Act, attempting to resolve these in a different way. And finally, there have been a couple of interesting tweaks or new components that we have introduced. One of the ones that I find particularly attractive is the default enrollment program that is allowed to states. It is a takeoff on some of the behavioral economics literature that has come out with regard to how to entice people into moving their retirement accounts when they change jobs, their IRAs, or other ways to increase savings by having the default be that you do it with an opt-out if you don't want to, rather than having the default be that you don't do it because we know that changes the probability and likelihood of an outcome in very significant ways. So you continue to give people the option, but you provide a default. In this case, the default will be a plan if the state chooses to go that route, where the premium is covered by the subsidy, so it is not imposing a cost that individuals don't wish to take if they are in that type of default enrollment. It's just a reminder, again, as I think we attempt to do in many places, that there are usually alternatives as to how we go about solving the problem. We shouldn't look at what we've done as the only or even the best. There are a lot of things that are going to be left to negotiate as part of the issues that we raise in this plan, specifically the size of the subsidy, whether or not to have them income related. There are pros and cons. We've indicated that about whether to do so or not because of what it does to marginal tax rates. The level of employer-sponsored insurance to allow tax-free. We've offered suggestions there also, but recognize this is very much a policy choice. The rate of the transition from where we are now to where we want to go, we wanted it clear. We recognize this needs to occur on a transition process, not a drop-dead date as of a particular date certain. And, of course, the whole method of setting subsidies. So we hope people take these recommendations in the spirit in which they are offered, which is a serious alternative way to solve the major problems that have plagued the U.S. healthcare system. Thank you.
Thank you very much, Gail. Tom?
Thank you, Joe. Let me get this up here. All right. We've tried everything else. I've got a long way to go in a short time to get there, so I'm firing up the warp drive. I believe that a picture says 1,000 words, but mixed, mangled metaphors can add another 500 per slide. I point out to you that this will be an archived broadcast that will be replayed in slow motion, so you can hear what I actually said. It'll include the links for those of you who didn't start watching movies more than 20 years ago. And you can also play it backwards, where you'll subtly hear the words Obamacare is dead if you do it carefully. All right, I was tempted to do an opening disclaimer on this since I am nominally an author. I thought I'd do the Charles Barkley defense for his own autobiography in which he said he was misquoted. He didn't go so far as to say that not only did I not write it, I didn't read it. I guess I don't have that ability, but I'll try to operate within those parameters. Look, let's say what's good inside. Unlike my comments, this is a serious effort. Jim did a terrific job within the limits of dealing with other people, the constraints of the project, and what we're ordinarily most comfortable with. And there's some good, opening ambitions, which hopes that if the moment strikes, something could happen. Getting from great principles to problematic policy details may be a different story, but on the other hand, it could, I said already, it could be worse, which for me is high praise indeed. As an opening thought, though, let's think about the role of think tanks in moving from principles to policies to politics, trying to do all of them or perhaps figuring out what the main job is. One ancient concept of a think tank was to highlight where we should go, what's the best destination. And then if you can't get there, curse under your breath and explain the various constraints. Saying, this is what you want to do, this may be what they'll allow you to do, and just kind of stop there. Or you can move on then to how to compromise those principles within the particularly limited elasticities of the already embedded maze of existing federal and state policy structures. Then if you want to go even further, you try to take on the political legislative role without actually having to run for office. Now, there's kind of two bipolar views about the Affordable Care Act right now. The supporters are, it's a trip back to from here to eternity. It's over, it's done, get used to it, and we're moving on from there. The alternative concept is just a little bit of a push and a gust, which means it'll be gone with the wind, and frankly, we don't give a damn beyond that. Now, there's also an idea that it doesn't matter. The people just don't yet understand what the real message is. It's a messaging problem. So until you figure out we've got a failure to communicate, you're going to go back in that box, and the captain is going to beat you a little bit further until you figure out what's going on. It's Cool Hand Luke for those of you who have a limited experience. Well, this will all be on the other end. Now, we can also mimic the political process and decide, how much the sausage looks. That's at least homemade as opposed to the wholesale version.
And what could go wrong with a plan that's handcrafted by experts? I mean, 10 people know a lot about healthcare. We again have the vision of the camel, which of course is a horse designed by a committee with the appropriate designer genes. All right. On to some substance. The plan in order to get from here to there, and these are just choices. Make some leveraged bets. May come up right. Now that's black and red. It really should have been red and blue, but you get the general idea as the numbers come up there. Let's talk about some of those provisions in terms of leveraged bets within how the plan is constructed. Age-adjusted fixed dollar tax subsidies. It's been around for a while. Pros and cons on that. You age adjust, you don't income adjust. If you have these relatively flat, you're also prescribing a system of regulation to the extent we have a free market out there anywhere on how premiums are priced, where you're going to have age-adjusted pricing of everything because it has to match up with the subsidy structure. There's also a heavy investment in the power of marginal work disincentives. Not only everybody hates the IRS and don't want it to be income tested, but the argument is if you cap it as a fixed contribution, you'll get all those folks who otherwise were just sitting around begin to work a little bit harder. There's some marginal returns on that, and the CBO will now give you, $2 million, and Casey Mulligan will go even further. But there's some question as to whether that's the driving force that's worth the investment for, in effect, capping any flexibility within what things actually cost as opposed to how much you're subsidizing them. We've got the move to, which is good, to per capita Medicaid federal funding, but we put it into two boxes: everybody who's healthy and everybody who's not or is old. But perhaps maybe a third box might be just people who are old who are getting subsidies as opposed to disabled, which is a different horse of another color. Auto enrollment, Gail was.
Yeah, you're there. You're there.
Auto enrollment is a question as to how far you're creeping toward a different version of an individual mandate and the political problems that triggers. Now, it does get you a budget score. However, what it basically does is not get you very much coverage depending on how you want to do it. Why don't we just cut out the middleman? And give it to the folks we really want to give the money to, which is hospitals or people who are treating people who aren't insured, and then cut out the arrangement of saying, well, you've got this comprehensive insurance, except you can't use it until you've already spent a lot of stuff along the way. There's a disclaimer on this, though, because it's really left up to the states, and you have mutual deniability. People who are in a red state say, my state would never, auto-enroll me in this. Keep in mind that we just repealed auto-enrollment for large employers, 200 and above, so apparently it's only small workers who we can impose this upon, as opposed to folks who already had pretty good insurance. We just try to nudge them over to the side. I don't have on here the delegation of the hard decisions, not to patients, not even to doctors. We pretty much delegate the real hard decisions to state politicians. As I pointed out before, they may lack market share, but they're still mice studying to become rats. And the question is whether they can get more scale on that front. No strings HSAs, it's kind of a nothing down approach. You don't have to actually have any cost sharing whatsoever for the front end of this, which is a straying from the original purpose of HSAs, but it's handing out money to folks for good reasons because we like them better than other ways we hand out money. This is also very budget scoring driven, which and it's a necessity of operating in Washington. People who actually read the document tomorrow or today on the scoring will see that the accusation will arise, well, you're just balancing the budget on the backs of the elderly. And I say that's only because we lack political support to balance it on the backs of the poor. So a lot of the savings do come out of Medicare. There's another way to deal with those Medicare, which are needed in any case to keep the program alive. It was pioneered a while ago, and there's the solution right there, lockbox. We didn't come up with that proposal, though, thankfully, as Al did. Some other leverage bets. The final one, of course, is the Cadillac tax. We're trying to squeeze some more mileage out of it. Not because we need the cost constraint, we need the dollars. As Alvy Singer said in Annie Hall, it may seem like a crazy thing, but sometimes you need the eggs. So the real reason is we need those tax dollars in order to pay the subsidies to other people and move them around in the budget. And that's the larger driving force, aside from budget scoring reasons, as opposed to some noble cost discipline. Could we be misreading the political moment, saying that there's that time for that thoughtful Republican replacement proposal? There is a possibility that we might be not listening to what the folks who are going to vote, or at least show up in polling, would indicate. There are possibilities for some other approaches in light of that political moment. We could build a beautiful wall around the regulators at HHS, trying to climb out over it, but not able to issue their latest edicts. Or we could decide that we simply want to cut off the ACA and Obamacare once and for all, end it in one clean sweep, kind of a form of decapitation, which has been tried before. Now, the point is, as young Frankenstein said, it could work, whether it's these more drastic proposals or the proposals in this plan. So there's always, hope anew as to what could occur. Is that all there is? As I've said, applying ad nauseum in many editions over the last couple of years, there might be some things you want to do than being insurance plan centric, financing centric, other ways to figure out some clues and get beyond our blind spots as to what would actually improve health outcomes, reduce costs, and actually give people a different range of choices. If you look at those clues very carefully on the body, you might see, you might see such things as social determinants, early education, family structure, health behavior, maybe even delivery system reform. Those are things that would actually both change what's going into the system and make it a little bit more efficient. But we don't usually have time to get into those because we're used with the familiar what moves the levers and what's still around there. So I'm always challenging this saying, okay, what's your plan? You can see in the distance the plane is about to arrive at Fantasy Island. About more than 20 years ago, I actually offered this in November of 1993. It was a detailed proposal which didn't have to go through Congress, was kind of a self-help approach to it, and pretty much took you through ways it can be implemented tomorrow if you're willing to do it. And at the end of the day, you pretty much end up the same place we all do, and so drive home safely. Thank you very much.
We should have had him go first.
So, Lanhee, you did say something about releasing the details of our emails. I believe they've been released. Well, for far gentler criticism, we'll go to John Hallahan.
Okay. Is that on? I can't tell.
Yeah, you're on.
Okay. Okay, so it went through the paper yesterday, didn't get all the way through. It's a long paper, very thorough. It's impressive how much thought went into all this. But I'm going to limit myself to the comments on the ACA and Medicaid and say some things in no particular order of importance, but hopefully I can get through a bunch of stuff. One of the things, the way the paper starts out, it's sort of like on the one side we have federal control and heavy government regulation. On the other, we have consumer incentives and market mechanisms. So you've got good set up against evil, and then we proceed from there. The reality of it is there's a hell of a lot more nuance, and I think Gail got into this a little bit. And the example would be the marketplaces in the ACA. You tie the subsidies to the second lowest cost silver plan. People who want more, a more expensive silver or a gold or a platinum plan have to pay more. If they want less, they can get the savings through a bronze plan. The silver and gold plans all have HSAs. These plans tend to have large deductibles. Even silver have deductibles around $3,000 for an individual, $6,000 for a family in 2016, and these are medians, so they can be higher. It's resulted in fairly robust competition in these markets, particularly in larger markets. So it seems to me this is a long way from big government, and it's certainly a long way from single-payer systems. It was mentioned here that, and just thinking about the proposal that's here, it wasn't clear where the tax credits are going to be set, but I think if this is really going to save money, the tax credits aren't going to be super high, and that'll mean that people will have to buy plans that have pretty high deductibles and narrow networks. So I don't think you're getting out of that problem. Empowering citizens has to be good, right? But I'm not sure what it really means operationally. And I guess where it worries me a bit is how much power and ability individuals have to do to, make their way through the health system, particularly in a world with tremendous amount of provider consolidation, hospitals buying other hospitals, hospitals buying up physician practices, now insurers in response to that, there's more consolidation there. So it's not an easy world at the individual level to fare, even with your high deductibles and HSAs and so forth. That should make you more conscious of what you're doing. Improve the federal fiscal outlook, hard to disagree with that. And this may do that, but it really depends on where you set the tax credits. But I just wanted to say that it can easily be overlooked because you hear all the time about continuing the surge in healthcare costs and so forth. The fiscal picture that we face right now is very different than what people thought it was 5 years ago. And a good chunk of this is not due to the ACA, but some of it is. The ACA, back in 2010, projected the coverage provisions of the ACA would cost $921 billion between 2014 and 2019. It's now $686, a 25% reduction. Our own work that it looked at several years of projections by CMS showed that even with the ACA projections or ACA expansions in 2010, they projected over a 6-year period 23.6 trillion in national health expenditures. The latest projection was 21.0, so it's 2.5 trillion less than was originally forecast. There's a lot of reasons for that. It's the economy stayed slow. It's what's happening in the private sector, but some of it is things that are in the ASA and unanticipated effects on the spillover of payment reductions on the use by private payers, more reductions in use that was anticipated, fewer readmissions, marketplace premiums coming in lower, and so on. Fourth, the cap on the tax exclusion. We actually completely agree with this, and I think I'm glad that you went for a cap rather than ending it until you have something that's in its place where people can go. And I think the optics of the cap on the employer exclusion are probably better than the Cadillac tax. Distributional effects are really largely the same, and we put out a paper on that. But I will say that other than people at AEI and at the Urban Institute, nobody else buys this, so I don't know that that's going anywhere. The fifth is age-adjusted tax credits, and I think they're okay in principle. The ACA actually does this by capping individuals' obligations as a percentage of income. Since premiums are higher as you get older, there's more of a subsidy. But it also adjusts for income, and as the paper points out, this is really complicated, and it's a mess. There's no doubt about that. But the trade-off you have is that you can have small tax credits, and they can be age-adjusted. But if they're small, they're going to be inadequate to allow lower-income people to buy decent coverage. If they're large credits that are adequate for everybody, then it has a high budget cost. So then you're back to the only way you really deal with this is to target it by income, and you deal with the mess that you have. And maybe you just deal with it by accepting some amount of error in it. But there's no good options here. The flexibility over benefits, and this is wasn't discussed as much today as it was in the paper, but let me just say that there is flexibility over this in the ACA. States can choose among several options. They tend to choose the most popular small group plan and have those benefits. There's a range of actuarial value options, and insurers can mess around with deductibles and out-of-pocket costs to get to different places and reach a certain actuarial value level. And even the same insurer will offer several plans at the same AV level. The complaint about the ACA that I hear is that it's way too complicated. There are way too many choices, and deductibles are too high. And it seems to me that if I read this proposal right, it would exacerbate a lot of this. Letting states decide over what the benefit package is. That may work, and it will work for sure in a lot of places, but it's not always going to work. And if the states choose a benefit package, let's say, facetious example, that they cover physician care and out-of-pocket drugs or over-the-counter drugs, Congress probably wouldn't like that. Congress is going to have some say over the use of federal dollars and what it's going for. So at the end of the day, as much as you may not want to, I think there's going to have to be a federal role in defining what a benefit package is. And it doesn't have to be as generous as what's in the ACA. You could cut back on essential health benefits, but what you have to realize when you cut back on that, you're saying that those things that we're no longer covering, there's no pooling of risk. And in a lot of states, adult dental care isn't covered. So if you have bad teeth, you're on your own. Okay. Mental health and substance abuse. Do we really want to not risk pool for those things? I mean, right now, mental health is being talked about all the time as the reason for gun violence. Substance abuse is raised now because of heroin addiction and concern over that. So we can cut back on the scope of the benefit package, but you have to realize that when you do that, you're no longer pooling risks. You're segmenting risk. Continuous coverage in lieu of the individual mandate. It recognizes that you just can't sign up at the end. It just does it in a different way. But it does have strong penalties, and I think those penalties are so potentially so strong that it is in effect a mandate. That if you have a lapse in coverage, you can be underwritten or denied coverage. So if you're healthy, the underwriting is really not a problem. You're going to get standard rates. But if you're sick, you could pay very high premiums or go with a gap in coverage. So the individual mandate that we have now has penalties that vary with income. This would have penalties that vary with health status. And it may turn out for a bunch of people that's not such a good thing. I think if there's going to be an alternative to the individual mandate as is right now, we ought to look at what Medicare is doing in Part B and D, but that's a broader discussion. That's not easy either. Medicaid provisions, a lot of what you're proposing I like. The fundamental argument is that it's too costly a program. I don't think that's true, and I think a lot of studies show that when you control for risk, it's not particularly expensive compared to private coverage. But there is an incentive in the matching rate structure to overspend. That's talked about. I think the most egregious example of that is the way states have used provider taxes and disproportionate share payments and all, and that's a national disgrace and it's not as understood as well as it should be, but it needs to be dealt with. But I think the real reason for Medicaid expense is enrollment growth, and it's not because states have expanded enrollment, because most haven't, but because we've had a large growth in the low-income population over the last 15 to 20 years, and that's that is a big problem. That is not going away, and any proposal is going to have to deal with that. Dividing Medicaid into two, I think it could be potentially really good. And integrating it with tax credits is also a good idea. I think what Arkansas is doing, the Medicaid program, is really interesting and important down there, and it's really shaping the market for people with private coverage. But what the problem then gets in, if your tax credits aren't income related, it's not as easy to see how that works as it is in the ACA or under current Medicaid. The allotments and the per capita caps, what's stated there is it would be based on historical spending levels. There's tremendous variation across the country in what states do. So roughly, if I remember these numbers right, and I haven't looked at them real recently, but acute care varies on a per capita basis by about 3 to 1, long-term care by about 10 to 1. Aged and disabled, I would guess, is more or less 5 to 1. It's just hard to see the federal government allocating per enrollee caps that give New York $10,000 and California $2,000. I just don't think that's going to happen. You could say, okay, we'll give you the national average, but then you're creating a ton of losers. And that probably won't happen either. So in principle, it's a good idea, but it's hard to see how you get there. On Medicare, I didn't read that completely, but I think there's a lot there that is good. And I think combining A and B premiums, if you could even figure out a way to get D in there, that would be good. Uniform deductibles, out-of-pocket caps is great, particularly if it could include D. The proposals for Medigap are good. I could even see starting the higher premiums that people face, starting to increase those at lower income levels to pay for some of this. And even for those people, it would be a good trade-off to get out-of-pocket caps, because then I think the need for Medigap is really reduced. And the final thing I'll just conclude with is raising the age of eligibility. And that probably really needs to be looked at, but I think it's hard to do it without income-related tax credits. And we had a proposal a couple years ago that would start to phase up the age of eligibility for Medicare for full eligibility to 67 and maybe beyond that, but would allow people on using the same as the ACA income-related caps to buy into Medicare. But one way or another, I think people at those ages need to start to pay more for Medicare or for health care if you can figure out how to do that. But I do think there's a problem unless you somehow income relate these tax credits. So I'll stop with that. And
Thank you very much, John. That was an incredible summary of very important points. We'll hit a few of them in the discussion, but we won't hit all of them. Next, we have Chris Jennings, who will wrap this part of the program up. Take it away.
Well, it's, can you hear me? Yes?
Yeah.
It's okay, you can hear me? No. Now can you hear me? Is this a plot here? You just cutting me off from the beginning, Joe? I would say a couple things. First, some of the advertisement of this program might have suggested that John and I were somehow authors of this product. We were not, clearly, and it's certainly understandable that we weren't. So I think you have achieved a clear consensus amongst conservatives, and that's progress. That, to me, that's really an important dynamic, and I would first start off by saying it's really an important development when you have a serious conversation about a policy rather than just a discussion about repeal. Otherwise, it's not going to go anywhere in any context. I do think that it's fair to say that it's primarily a potpourri of past policies, a creative application of them, but nonetheless sort of a potpourri. I think that, but I think it's as I say, I think it's a creative application of them, and I think it's worthy of some serious discussion. I would note that when we talk about healthcare, I want to underscore something that John said in passing, that healthcare is going to be a big challenge for us going forward in terms of our healthcare relative to the budget. There's no question about it. Ironically, we're sitting in Washington this week when we're about to pass a $1 trillion unpaid-for tax extenders package, which is going to significantly increase deficit and debt and put more pressure on that debate. Maybe that's a point of that maybe that's a point of that policy, but it definitely is going to happen. I think rather than redo a lot of what John said, I will say that if you look at sort of the public's general perceptions about healthcare versus policymakers, what they're particularly concerned about is a trend to what they feel as not great success at cost containment, but in their views, a little bit more success at cost shifting to them through higher and higher deductibles. There is a potential problem with your policy, is that in some ways you are indicting the ACA as a very Cadillac-oriented policy that provides for extraordinary coverage for people. But I think right now, both because of that policy, because of perceptions about the Cadillac tax, because of trend rates of what employers have been doing in terms of the design and benefits packages, the public feels the contrary is true, that the burden is becoming greater. And your policies could be interpreted as actually accelerating some of those trends by saying, okay, insurers or states, you can design what you want, and the federal government's going to subsidize it, and by definition, the value of those benefits might be less, and cost sharing may be higher. I don't think that that's going to be a particularly politically sustainable policy. You talk about, I wanted to talk to you about the prescription drug discourse. I think that, I don't know if you had any policy on prescription drugs. Do you hear in this? We
weren't specific on
okay.
one health benefit.
But I would say I don't understand what the notion would be about what choice would do relative to being able to lower prescription drug cost or the burden of accessing drugs. If we are going to have a private marketplace that use PBMs to negotiate for drugs, you will have formularies, and as along the lines that you suggest, and most of those formularies, I think, do have prior authorization provisions for people to access drugs if there's a medical necessity. I kind of see two, at least currently. There may be some future approach to dealing with drug costs, but it's either going to be more of a regulatory approach or an approach towards markets that use formularies to negotiate and try to leverage competing drugs. And to the extent that we can do anything to help the marketplace approach, we probably need to accelerate getting more products into the marketplace to help people leverage those prices down. But I don't see a dynamic that could exist where you wouldn't have some ability for the private sector to utilize formularies to negotiate drugs. Otherwise, I don't know how you get prices down. So we can just talk about that. I think CALAC tax, I just wanted to say that we're about to see the extenders likely, if there is a package, pass make the CALAC tax an extender. And for a 2-year delay. I think that policy was flawed or is flawed, at least in terms of indexing and geographical adjustment. I think that if you really are going to be talking about policies that are sustainable, you have to think about alternatives that are more workable. I would suggest if you're going to be doing your vision on CALAC tax, you address that. I didn't see you addressing that because I think your indexing was CPI, I think, which is one of the critiques of the current construction, that the tax was going to hit more and more plans over a period of time, and those plans were, cost sharing was going to be increasing as a consequence. At some point, we have to also recognize one other, I would say, and this will be the last point I'll make about the benefit structure, and what I think you guys suggest is the answer to address all evils is to address it through the HSAs and to have more tax deferred benefits for people to buy the products that they choose. John mentioned that a little bit. I will say this, that one question about using the HSAs in that context is what will be the distribution of what you're subsidizing. More and more people with higher incomes, of course, that will be very, very appealing. There's no question about that. All of us on this panel would love to have an HSS that we could have tax deferred. The question is the employer going to be paying for the individual, and the lower income population who does not have disposable income, how can they get that benefit? So as a consequence, I kind of see this policy as actually shifting tax subsidies federally that are indirectly subsidized by us, the public, to higher income populations and healthier populations away from people who probably need the coverage the most. And I think that is a very significant shortcoming of this policy. Again, let me commend you for having a policy. I'm happy to be here and I'm happy to take any comments. Oh, and Tom, quick question. Do you have tenure?
Day to day. We all are.
Thank you very much. Thank you very much, Chris. Those also very, very thoughtful comments. I found one particularly positive point in your comments, which was on the Cadillac tax, the idea that it's going to be delayed for 2 years. Thank God we're coming back to getting a must-pass health bill. You know, we gave up the SGR. Now we're finally going to get this.
We have a new vehicle.
Exactly. It's going to force Congress to do something every year. That's really good news.
And sometimes we may pay for it.
It's optional. Exactly. I'm sure people on the panel would like to comment. So, Gail, please.
Just a couple of comments. First, thank you. Those were both very thoughtful responses. John talked about the fiscal picture. It was quite clear that he was not attributing all of the reduced spending to provisions of the Affordable Care Act. There is a column about 2 months ago in The Economist that was reporting out on an OECD report that was released in August. That is something that people really need to look at. Basically, the title of the comment was "The Pause Before Fast Forward." And the bottom line of the message was that we in the United States like to think our slow spending is because of the clever policy interventions we've done. But actually, the reduction in spending, which was quite real if you look at 2000 versus 2009 and 2009 versus 2014, was less dramatic than the reduction for the OECD overall during those same periods. It is a reminder that there is, unless we want to think that there was a global reach to the Affordable Care Act, that it was much more the very deep recession, the global recession, followed by some of the euro currency disturbances, followed by an unusually slow recovery period, all of which, unfortunately, we've had to live through, but which now appears to be on the change. And that was for the pause before the fast forward comment. All of the forces in play that have driven up healthcare spending in the past, new technologies, aging populations in wealthy countries are there again, and we shouldn't fool ourselves that this reflects anything but the bad luck of having lived through a global recession. Again, this is, it was quite a daunting picture of what has happened. As somebody who has thought it was about 80-20 between the global recession and change in policy, this makes it hard to even decide whether that's present. It may be that some of the changes go forward. One comment on the prescription drug pricing issue. The first is, if you look at the increase in prescription drug pricing from 2008 on, it's important that you note only in 2014 was a rise in prescription drug pricing higher than the rise in hospital spending inflation or higher than the personal health care expenditure inflation. So what we have seen is opposite of what has occurred in the previous years, first point. Second point is the notion about what our alternatives are, I think, are particularly important to think about what happened in the Hep C market, which is frequently the poster child for concern, that while Sovaldi and Harvoni came on at high list prices, places like Express Scripts were able to have an effective price that was substantially lower. And as soon as AbbVie and some of the other drugs, Merck has reportedly have a drug that's about to be released, it looks like it had quite an impact, which leads to the concept that if we can find ways for the FDA to expedite the approval of competing biologics, the likelihood of being able not to make these cheap, but to make them lower price is at least a potential alternative, particularly important when you come across some drugs that actually cure diseases, as was true in this case. Some of the challenges of very expensive biologics that extend life for a month or two with unknown or bad quality are more challenging in terms of the ethics. But I think we have to be very careful as we go forward to not make the cure worse than the disease that we're facing.
I'll just say in follow-up, I didn't offer the issue of the expensive formulas as a sort of proposal for cost control, but an example of how the plans in the Affordable Care Act aren't consumer-directed insofar as providing consumers choice. But on the issue of cost control and the question of providing more expansive coverage for particularly catastrophic drugs for debilitating chronic diseases, if we look historically at where the productivity improvements have come from in medical care, it's come from technology, smart application technology, and in particular from drugs. We have not seen significant, if at all, productivity improvements on the services side. The hospital sector has been the sector most closely studied with respect to productivity. And the data in cancer in particular, in oncology in particular, shows that the productivity improvements that have come about from cancer care delivery have come about from the application, particularly of drug technology. The spending on cancer has been fixed as a proportion of total spending on healthcare at about 5% of total healthcare spending for a very long period of time, but it used to be that 75% of that 5% was on services and inpatient care and 25% was on drugs, and it's now completely inverted. 75% on drugs, 25% on outpatient care, because the drugs have moved care to the outpatient setting at the very same time that they've dramatically improved outcomes. I will say, just, to sort of an aside to what we're discussing today, but if we were thinking about trying to address the drug cost issue more directly, and I think the things we've done here by trying to change the structure of the delivery systems will address cost issues on the drug side, but there are things you can do to address it more directly. And I'll just offer two thoughts. It's a little far afield from what we're talking about here, but I think that there's a real problem with getting generic competition onto the market, particularly in these smaller categories where it used to cost, when I was at FDA, the rule of thumb was it cost about $1 million to file a generic drug application, and a category of drugs wouldn't become genericized till it reached about $10 million in total revenue. Now the rule of thumb is more like it could cost upwards of $20 million to file a generic drug application, and a generic category won't become really subject to a lot of generic competition until you reach about $50 million in generic drug revenue. So that you're seeing these situations where these small utilization generic drugs aren't subject to any competition until exorbitant price increases are taken, and then it starts to entice in generic entrants who can then afford to file generic applications because the returns are going to be higher, at least for a period of time. So there's a real problem, and there's also a problem that could take upwards of 3 years to get a generic drug application approved. So speculators, for lack of a better word, can get a perpetual monopoly over the course of 3 years by acquiring a small utilization generic drug and jacking up the price because they know that generic entrants can't launch for a very, very long time. That's a problem, and it's a significant problem. Also, costs of goods have gone up substantially. We've dramatically increased GMP costs to generic drug manufacturers over a very short period of time by the rapid implementation of new regulations on this industry. And so the cost of goods have gone up, and it might not sound like a lot when the cost of a generic pill goes up from 3 cents to 4 cents, but you amortize that over 86% of all generic drug use. All drug use is generic, and you bake in a 25% increase, and it's a substantial increase in cost to consumers. So that's a big problem. That's different from the issue of the high-cost specialty drugs, which is not what a lot of elected officials want to talk about. They always talk about the generic drugs that are pricing exorbitantly high because that's an easier discussion to have. No one wants to talk about a drug that cures cancer but costs $200,000 a year because it's curing cancer potentially. That's an issue as well. And I think there we need to allow manufacturers to more closely titrate what they're charging relative to the benefit that they're delivering. And the big impediment there is Medicaid. Medicaid prevents manufacturers from, for example, pricing drugs based on the indication. So, things are priced on volume. It makes no sense that a cancer drug is priced on volume when it's being used across a range of applications, some of which are delivering a lot of value, some of which might not be delivering a lot of value. There might be much less data associated with it. So you want the prices to fluctuate based on how the drug's being used. That can't be done in the marketplace right now. Those are two ideas. I think we didn't get to that in this report. We could have, but we were looking at more structural issues in healthcare. But I do think when you're talking about the formularies, and I agree with you, you need formularies to try to extract price concessions in the market. And some of the data that came out of the Grassley report showed that the health plans that got the best discounts from Gilead were the ones that had closed formularies and the tightest formularies because they were in a strong negotiating position. But when you're talking about these specialty needs, these chronic conditions, catastrophic types of ailments, you want to provide more flexibility, not less, because the productivity improvements in reducing future costs and improving outcomes historically have come from the technology.
And Joe, I know you don't want to have a discussion about drugs. I'll just say two quick things, very, very quick. One is that I just want to be very careful that people there's any suggestion that formularies don't exist in every single plan in America. I mean, it's whether they're an ACA exchange plan or they're not. There are formularies everywhere. There's an FEHBP and the blue chip in the Fortune 500 companies. They all use formularies. So let's not apply that.
Closed, though.
And many do use closed
Some
formularies too. So it's not an ACA issue. But secondly, I did want to say, and Gail, this is to your point, I think you're right, but I will tell you that if you talk to most analysts in the industry, they'll tell you that we do have a generic cliff, right? A generic mark cliff, so there will be less competition in the years to come. We are going to have issues with regard to both single source specialty drug prices in particular and generics. We got to deal with both of them. We don't have to do it here, but let's not suggest that that this isn't a problem. It is a problem.
We will definitely be talking about this at a much greater length over the coming year. John?
You may want to move on to other territory, but I just wanted to say one thing in response to
Yeah,
Gail.
please.
Okay, so this issue about whether the slowdown in healthcare spending has been the recession or whether there are other things going on has been around for 3 or 4 years now. And I think it's the recession plus other stuff, and that it has really made a difference. There's just so many, essentially from a variety of ways, one of which is that people had less income, but also because of changes in policy, both at the corporate level and in Medicare, and well, Medicaid's never been a good payer anyway, so that essentially turned off the spigot that providers could rely on. And by slowing that down, that forced structural changes in those institutions that aren't going to go away. The two things that I would say would turn it around, and it's not, is that if the economy really got extremely strong and we all felt we had a lot of excess money, we might want to put a bunch of it back into healthcare. That would turn up healthcare spending again. The other is the whole issue, and it's not unrelated to the drug issue in some ways, although I don't understand that as well, but the whole problem with provider consolidation, I think, is just going to be a huge, huge thing to deal with. And to the extent that nobody can negotiate with these guys, and you guys don't want the government to do it, then I think we have a problem. So,
Yes.
Won't individuals be able to negotiate?
You know, if your name is Donald Trump, I believe you can get a good deal. It's going to be huge. Unless anybody else on the panel has a quick comment to make, let's go to the audience with questions. And let's start there with Carl, right there.
Yeah,
Okay.
Carl Pulzer with the Center on Capital and Social Equity.
Is that on?
Do I have to? Oh, okay. So I'm glad to hear a lot of what's going on doesn't really have to do with the ACA. Like rising healthcare costs, inflation, a lot has to do with the underlying economics and political economics of the system, and it's been going on for a long time. Medicaid policy, the real politic of Medicaid policy for a long time has been put them in HMOs, let the corporate sector deal with it. Beginning with the first Bush administration, Republican policy has been doing that, and the Obama administration and the National Governors Association really went whole hog on it. Now they're even extending it to long-term care. My question is, we have a society that's increasingly separated by resources available to people. We have income stagnation. In the future, we're probably going to have more of a divide between those that have resources to spend on health care and those that don't. So with a vision of more choice for people with low incomes and moderate incomes, how much money are we going to have to subsidize them so the choice isn't between having insurance or no insurance or coverage or no coverage, or what kind of coverage you're going to have and how much freedom are you going to have? So where do you set that amount?
So really, this is a question about
Well, that's
how much subsidy you want to give. One of the thoughts that ran through my mind here when this discussion had to do with whether we want to have explicit or implicit payments by people. In the end, it comes out of our pockets. So there's an issue about the extent of redistribution. In my opinion, there's a real issue about the mechanism by which you redistribute. I think the exchange process demonstrates just how difficult it is to combine what is essentially an income redistribution program, you could call it a welfare program, with what's trying to be an insurance program. Transferring the money is very hard to do, and it was possible to do in Medicaid under circumstances that most people wouldn't accept, and poor people who were in that program didn't have a choice. Gail?
I mean, these are basically questions that the country has to decide, and particularly the people who are going to be doing the subsidy have to be willing to accept, because it involves either explicit or implicit transfers from some populations to other populations. One of the issues that we may or may not ever get to have in this country, because it requires a lot of adult discussion, which is hard to have, is, are we really trying to improve health? And if we're trying to improve health, can we ever start to look at the mix of the social determinants of health and how they interact with the use of medical care. Most of us understand that it's about 20% of your health outcome depends on your access to medical care, about 20% to your genetics, and 60% to the environment in which you live, work, play, and age. Those are very hard issues to discuss, and it's really not clear how people feel about it. We do feel a little better about trying to make more opportunities for education, particularly for low-income or disadvantaged populations. And that can have a lot of effects that play into social determinants of health. We can do it explicitly to try to improve health, or we can do it to try to improve equality of opportunity in the country. And a lot of times it depends on how we phrase it as to whether or not people will accept it. But I think just to point a figure of Medicaid managed care as though this was a bad thing, I personally think was probably the best thing that has happened in terms of trying to get people out of ERs as their place of regular care. You had this fictional ability to go to any physician who you wanted, except it really was any physician that was willing to accept a $6 payment for an office visit, which usually meant Medicaid mills or ERs where they were paid more. Whether this is a good system or not I actually think it was probably a better system than what people in Medicaid were typically receiving before that. Whether it's the best we can do for low-income populations, that's a whole different question. But these are very hard questions, and it has to do with how individuals in a society look at what they're willing to do, and especially those who are going to be called on to fork over the money.
Carl's original question put this in essentially static terms. We got these people with needs. How much money are we going to give them, as opposed to thinking how that might change in the future? Gail could have supplemented her percentages in terms of what produces health with a complementary percentage. How much of healthcare politics is about who gets the money, which is about 90%, and we leave the rest as a residual. The reason for carving back on it on the margin is not to be mean to people, to be cheap. It's to say maybe we should do something better, which would get better results. And it doesn't mean going in the same tried and true conventional channels, given what we know about what actually produces lifetime health, what might improve your engagement with the healthcare system, but those always end up being the poor cousins, because that's not what politics and the financing of healthcare is largely about.
Oh, God, I think we only have time for one more question. Because I think we're supposed to end at 11:15. Wait, you have to wait for the mic.
Hi, Vic Miller, fiscal economist, mostly retired now. You were talking about the economy and the impact on the healthcare costs and some differentiation, but by and large, slowdown in healthcare costs as the economy's been soft. Now it's stronger. But have you addressed at all the issue of what happens again when it gets softer, and when states with their per capita payments won't have the ability to finance the healthcare system as they have had suffering problems in the past?
Well, I think their proposal is a block grant, so they if they get enrollment increases because people become unemployed, it's a per person.
Per person block grant.
Well, or per capita, allotments, right, whatever you want to call it.
So it would automatically.
So it would deal with that.
That's
I mean, if it,
Yeah. I hate to stop this interesting conversation, but we have run out of time. Please join me in thanking the panel.
It's a good debate.
I think there's potential in the future for some of what's being tried to have an effect.
Well,
Indication-based price, allowing prices to fluctuate based on indication.
Other than the high deductible
but
plan.
I think it was supposed to go.
I think you probably have too. I'm not talking about it.